Kapil Kumar. The lecture consists of the introduction in what are the indications of spirometry, what are the contraindications of spirometry, how we perform a spirometry maneuver, what are the reference values that against which we calculate our values, and how to interpret the spirometry results. So, spirometry was discovered, first spirometer was made by Dr. John Hutchinson. He invented the first spirometer. It was a simple device basically used to measure the lung capacity and which he used while evaluating the candidate for life insurance. So, he found out that a patient's vital lung capacity correlates with his mortality during mortality chances during a surgical process. So there are two basic types of spirometers: volume measurement devices, these are obsolete nowadays, and flow measurement devices, pneumotachograph. These are the current generation of spirometers that we use in our practice nowadays. So there are two types of pneumotachograph spirometers available. One type requires PC or laptop for software for its software, and the other one are portable devices which are handheld devices and can be directly used to perform a spirometry maneuver. So this is a basic physiology diagram showing the tidal volume, inspiratory zero volume, expiratory zero volume, and residual volume, inspiratory capacity, FRC, vital capacity, residual volume, total lung capacity. So the spirometer will calculate functional forced vital capacity, forced expiratory volume in first second, and the ratio of that, and peak expiratory flow. These are the important parameters that are calculated by spirometer. The residual volume is calculated by high-end devices, the BLCO devices. So the inspiratory capacity, FRC, all these are calculated by high-end devices. So what are the indications of the spirometer? The indications are divided in three categories. First one, to diagnose a disorder. Second one, to monitor the patient. And third is to categorize the patient as a disabled person or impairment evaluation. So, for the diagnosis, indications are to evaluate any symptoms, signs, or any abnormal lab results. For example, an abnormal chest X-ray, any abnormal CT, or any abnormal ABG finding. The second is to screen individuals who are at high risk of pulmonary disease. For example, smokers or patients who are working on in hazardous or dusty environments. Another indication is to evaluate the pre-operative risk of the patient. This is commonly done in cases of thoracic surgery, in which we are going to resect a portion of the lung. Another indication is to assess the prognosis of patients, for example, in COPD patients, to assess their prognosis and their risk of mortality in the near future. For monitoring of patients, to assess the response of therapeutic interventions and to monitor the progression of the disease. Contraindication: there is no absolute contraindication of performing a spirometry. Relative contraindications are attributable to cardiac illness, for example, acute myocardial infarction within 1 week, systemic hypertension or hypertension, significant arrhythmias, heart failure, uncontrolled pulmonary hypertension, poor pulmonary, clinically unstable pulmonary embolism, or history of syncope related to forced expiration or cough. Attributable to increased intracranial or ocular pressure, cerebral aneurysm, last 4 weeks. Recent concussion with continuing symptoms and eye surgery within past 1 week. Attributable to sinus or middle ear pressure, sinus surgery or middle ear surgery or infection within 1 week. Attributable to increase in intrathoracic or intra-abdominal pressures, presence of pneumothorax, thoracic surgery within 4 weeks, abdominal surgery within 4 weeks, late pregnancy, and infection control issues. For example, any patient having active or suspected transmissible respiratory or systemic infection, including tuberculosis. Any physical conditions predisposing to transmission of infection, for example, patient having hemoptysis, excessive secretions, oral lesions, and oral bleeding. These are only relative contraindications. There is no absolute contraindication to spirometry. So, what a patient should expect during the spirometry maneuver. First, we will measure his age, height, weight, and these are filled into the system, and the nose is clipped to encourage mouth breathing. Then the patient will perform post-vital capacity maneuver. He will blow into the mouthpiece connected to the spirometer, and the test is repeated at least 3 times by giving rest in between these maneuvers, and then the spirometry will create the report of the patient. So, what are the 3 test checklists? A patient should remove any loose dentures and chewing gum and ensure empty bladder, rule out any presence of any contraindication. Patient should avoid smoking for 24 hours before the test, alcohol for 4 hours before the test, heavy meal for 2 hours before the test. He should avoid doing rigorous exercise 30 minutes before the test, and he should be wearing loose fitted clothes. Avoid wearing tight fitting clothes. And if we are performing the maneuver in patient who is already on treatment, then certain medications are to be stopped. Short-acting beta agonists should be stopped 6 hours before the test. Long-acting beta agonists should be stopped 24 hours before the test. Ultra long-acting should be stopped 36 hours before the test. Short-acting muscarinic antagonists should be stopped 12 hours before the test. Long-acting muscarinic antagonists should be stopped 48 hours before the test. So, what is the technique? The patient should inspire maximally and expire forcefully immediately within 1 to 2 seconds of inhalation, and should expire forcefully and as rapidly as possible into the spirometer, and should continue to expire. Usually the machine will prompt when to stop expiring, or if patient is continuing expire, it should continue to at least 15 seconds according to the current guidelines. 15 seconds or until and unless the machine will detect that the flow has decreased, and it will automatically prompt that patient to stop the expiration. And after stopping the expiration, patient should perform an inspiration which to calculate TNC. And if the patient performs an adequate maneuver, then almost every time the acceptability criteria and repeatability criteria are achieved. So, what are the acceptability and repeatability criteria? The patient should have maximal effort, no cough during the first second of the starting of the post-vital capacity maneuver. Patient should have a good start, and there should be no closure during the first second. So the first seconds are very important because FEV1 is calculated during those seconds. So the first second, there should not be any hesitation, gloating closure, or any cough during that maneuver. And patients should achieve one of these indicators. Expiratory plateau should be less than 0.025 liters. It is usually automatically detected by the machine, and the machine will prompt when this expiratory plateau is achieved. Expiratory time should be more than if the expiratory time has achieved for this ratio is to be considered as abnormal. So what are the this is one of the most important study done in India, done at my alma mater by our the ex-director, Dr. Professor S.K. Chawla. This study was done in North Indian population, and they calculated reference values for North Indian population. It was done in Delhi, so we are still using these reference equations to interpret the results of Indian population, North Indian population. So another patients of obstructive airway disease, if the reports comes out to be having obstructive airway disease, then we will perform a reversibility test also. So we will give the patient 4 cups of salbutamol and repeat the maneuver after 15 minutes and calculate the change in the FEV1 and FVC. So there are various different societies have different guidelines to document reversibility. The ACCP says that improvement in FEV1 should be more than 15%. ATS says that improvement in FEV1 or FVC or FVC of 12% or and more than 200 ml is to be considered significant. ATS NERS considers improvement in FEV1 and or FVC of more than 12% and 200 ml. Gold considers improvement in FEV1 only of more than 12% and 200 ml. So interpretation, we will look at the loops. 2 types of loops are generated. The most commonly observed loop is the flow volume loop, and in case of asthma, there will be a concavity during the exhalation maneuver. In asthma as well as in COPDs. In restriction, the volume of flow volume loop will be less. In variable intrathoracic obstruction, there will be volume loss in the expiratory loop, and in variable extrapolation obstruction in the inspiratory loop, and in case of fixed obstruction in both loops. So how we will interpret the result of spirometry? First we will look at the ratio, FEV1 and FVC ratio. In case of COPD, less than 0.7 is considered abnormal. In rest of the patients, less than lower limit of normal is considered abnormal. If it is present, then we will look at the FEV1 values. If FEV1 values are lower, then there can be 2 scenarios. Only FEV1 is abnormal, lower, then it is purely obstructive, and if FEV1 and FVC both are low, then it could be mixed obstruction with concomitant restriction or airgully. And in cases with FEV1 is low and FVC is normal, then it is only purely obstructive defect. And if FEV1 or FVC ratio is normal, then we have to look for restrictive disease. If the patient has restrictive disease or not. If FVC is low, then it will suggest a restrictive defect. Then we have to do further advanced studies such as DLCO, total lung capacity, all these studies. And if FVC is normal, but then we will look for FEV1. If FEV1 is low, then it is more considered non-specific. If FEV1 is also normal, then in cases where FEV1 by FVC ratio is normal, FEV1 is normal, FVC is normal, and we are still suspecting that the patient is having any respiratory disease, then we should go for DLCO. Because in early ILD patients and in cases of patients with pulmonary vascular diseases, we can find any abnormality, in DLCO tests. And if the DLCO is normal, then the whole pulmonary function tests are considered normal, and we have to look for alternate diagnosis. This is our PFT lab at Sarvesh Hospital. The larger machine which only is The machine having all the three tests in one: spirometry, lung volumes, as well as DLCO. And these are rest of the associated machines. Pheno machine for fraction and axial nitric oxide measurement. And this is a FOT device. This is used in children who cannot perform maneuver of spirometry. In these cases, we can use this force oscillatory technique to measure their lung resistance and their lung compliance. Thank you.
I was aware they are still using the US and the European reference values. This is the first time we have admitted that we have an Indian reference value set also. Is it being used extensively? What high information was that we are still using the European and American reference values?
Sir, the machines are made by Americans. Reference values, because we have to calculate our values with our set of data. So we cannot compare our data with European and Asian population. These are generated at Delhi and includes our North Indian population. So in guidelines is that the reference values should be made from their own set of data.
Is there a role of pressure values and the volume that have been generated during the spirometry? The role of pressure and the volume that are generated during spirometry. Is there a role of...
Sir, for them there is a separate machine for that. MIT and MEP, these are generally used in, because they have separate machine. It's a simple portable machine that calculates the MIT and MEP values.
परफॉर्म करना कंप्लीट डायमंड शेप आपको कर लेके आना, तो नॉर्मल पर्सन अगर करे तो वो भी रिपीटेबिलिटी नहीं होती आमतौर पे। क्या आप डायरेक्शन या देते हैं पेशेंट को या ट्रेनिंग मिलती है जिससे वो टेस्ट को अच्छे से परफॉर्म करे? एंड इज देयर एनी एज कॉन्ट्राइंडिकेशन इससे इसका स्कोप इंडिकेटेड है हमें सारे में?
So if the patient is non-smoker, he will be able to do up to 90 years of age. But if the patient is having disease, he won't be able to do any, and during any acute exacerbation of any disease, we are not usually not doing spirometry in those patients. And so what was your Sir, we will, the technician will demonstrate the maneuver first. And it will take time, but if you are having good technician, he will get the results.
For chronic obstructive airway disease for diagnosis, you take we broker director FEC ratio or post broker?
Post.
About whether having a therapeutic response direction.
It is usually done in follow-up during the follow-up. We give treatment and assess the response during next week.
Like immediately after the person takes the inhaler and then he undergoes the test again. I mean, if he gives a good response to that inhaler, so his all the parameters. So will they improve immediately, or you do it after? Say after the therapy of 3 to 6 months?
There is one issue in that. The fast-acting inhalers, which are using for this reversibility test, they are usually known as respiratory. And what we are giving on long-term basis, they are usually long-acting inhalers, and they don't have that fast onset action. At present, the guidelines are saying that we have to perform with short-acting beta agonists. The reversibility maneuver should be performed with SABA only. And what we are giving for treatment is long-acting.
So you are repeating the spirometry after
Yes.
how long period?
Usually after 2 weeks of
2
treatment.
weeks of
In case if the patient is having severe epilepsy, then we have to wait a little bit longer.
Okay. Thank you, Dr. Kapil.
Thank you.